Good afternoon. My name is Meg Achilles. Thank you for attending. The purpose of this short seminar is to help you as an exercise physiologist understand blood lipids and how they relate to cardiovascular disease, something which we would all come across in our practice. After this presentation, I hope that you better understand blood lipids, what they are and how they are measured, and the associated risks of elevated blood lipids for cardiovascular disease. Finally, I'll run through the implications elevated blood lipids has for your clients and how they may present to you as clients, and how blood lipids can be addressed through exercise interventions. First of all, what are we talking about when we refer to serum lipid blood levels? Blood lipids are vital components of the cell membrane, essential for cell growth, division, and the maintenance of cell integrity. Blood lipids, or blood fats, are mainly comprised of fatty acids, that is, triglycerides, and cholesterol. Triglycerides store unused calories and provide the body with energy, and cholesterol is used to build cells and certain hormones. Because triglycerides and cholesterol can't dissolve in the blood, they circulate throughout the body with the help of proteins that transport the lipids. These are called lipoproteins. There are four main classes of lipoproteins, classified based on the thickness of the protein shell that surrounds the cholesterol. These are chylomicron, which is derived from the intestinal absorption of triglycerides; very low density lipoprotein made in the liver for the transport of triglycerides; low density lipoprotein, a product of the very low density lipoprotein metabolism and the primary transporters of cholesterol in the blood through arteries; and high density lipoprotein, which is involved in the transport of cholesterol back to the liver, otherwise known as reverse cholesterol transport. Our serum lipid blood profile relates to the measurement of the number of lipids in our blood. A simple fasting blood test can provide us with blood lipid profile, which your client can do at their local pathology or general practitioner's office. From this test, we can ascertain measurements for our low-density lipoprotein cholesterol, or LDL cholesterol. This carries cholesterol to the peripheral tissues and is commonly referred to as the bad cholesterol because excess of LDL cholesterol builds up in the walls of arteries. High-density lipoprotein cholesterol. HDLC is protective and removes cholesterol from the tissues and carries it back to the liver. High-density lipoprotein cholesterol is often referred to as the good cholesterol. And finally, triglycerides. Triglycerides are the most common type of fat in the body. They are present in the blood to enable the transfer of adipose fat and blood glucose from the liver. These three measures are then combined to determine our serum total cholesterol. The total cholesterol score is calculated using the following equation: your HDL cholesterol plus your LDL cholesterol plus 20% of your triglyceride level. As a side note, I have to admit I have a real issue with the term good and bad cholesterol, as I think there is a reason and a role for everything in our bodies, and I think this terminology only perpetuates misunderstanding. So personally, I try and avoid using these terms with my clients. Rather, I try to educate them on the target LDL, HDL, and triglyceride levels. If blood lipid levels are found to be abnormal, one is said to have dyslipidemia. There are three subcategories of dyslipidemias associated with excessive blood lipid levels: hyperlipidemia, which refers to excess cholesterol, both total cholesterol and or LDL cholesterol, and triglyceride levels; hypercholesterolemia, which refers to excess total cholesterol or LDL cholesterol only; and hypertriglyceridemia, which refers to excess triglyceride levels only. Some cholesterol is essential for optimal health. However, when blood lipid levels are too high, cholesterol and cells can become plaque in the wall of the artery. As a result, these extra fatty deposits on the arteries lead to the hardening and narrowing of the arteries, which reduces blood flow and increases blood pressure. This is atherosclerosis. In this regard, the serum blood lipid profile provides a measure for the risk of atherosclerosis and provides a measure for the risk of cardiovascular disease. The Royal Australasian College of General Practitioners recommends that adults have their blood lipids assessed every 5 years after the age of 45 or from the age of 35 years for Aboriginal and Torres Strait Islander populations. In Australia, we're a little different to the US in that we report blood lipid data in standard international units of millimoles per litre. People are considered to be at risk if the total cholesterol is found to be over 6.5 millimoles per litre. Moreover, if HDL cholesterol is low, that is less than 0.9 millimoles per litre, and or triglycerides are greater than 1.7 millimoles per litre, people are considered to be at risk. For people that require treatment for their cholesterol, the Australian guidelines, as outlined by the RACGP, set the following target levels to aim for. For your low-density lipoprotein cholesterol levels, to aim for lower than 2 millimoles per litre. However, people who are considered at high risk, such as those who have had a heart attack, should aim for LDL cholesterol levels less than 1.8 millimoles per litre. Australians should also aim for high-density lipoprotein cholesterol levels of 1 millimole per litre or more. High-density lipoprotein cholesterol is protective against cardiovascular disease, so therefore high levels are good. Australians should also aim for triglyceride levels of less than 2 millimoles per litre. Therefore, in a healthy individual, we would like to see low levels of low-density lipoprotein cholesterol, therefore not as many lipoproteins in your blood, increasing your chance of fatty deposits in the arteries. You want to see high levels of HDL cholesterol, which means more lipoproteins transporting cholesterol back to the liver. Low levels of HDL cholesterol puts you at a high risk for cardiovascular disease, even if your LDL cholesterol or your total cholesterol is normal. And we want to see low-level triglycerides, as high triglycerides contribute to the development of atherosclerosis, hardening and narrowing of the arteries. You do not have to be abnormal in all levels to be at risk. A high triglyceride level combined with low HDL cholesterol or high LDL cholesterol is also associated with atherosclerosis. Even just small changes to your blood lipid levels can have a big impact. The American Heart Association notes that for every 1 milligram of high-density lipoprotein cholesterol per 1 deciliter of blood. So what influences our blood lipid levels? Elevated blood lipid levels can be affected by modifiable factors such as our diet. The consumption of high amounts of saturated fat and cholesterol in the diet can result in high levels of blood cholesterol. Saturated fat is the main culprit, but cholesterol in foods such as in meat, eggs, dairy is important too. Our weight. Being overweight is a risk factor for cardiovascular disease and tends to increase blood cholesterol levels. Physical activity. Not being physically active is a risk factor for cardiovascular disease, as physical activity helps to lower our low-density lipoprotein cholesterol or bad cholesterol and raise the high-density lipoprotein cholesterol levels. Our blood pressure. High blood pressure is often seen in patients with excess blood cholesterol related to atherosclerosis. Other factors that can influence blood lipid levels include our age. As we get older, our cholesterol levels tend to increase. Our gender. Before the age of menopause, women are found to have total cholesterol levels lower than men of the same age. However, after the age of menopause, women's low-density lipoprotein levels tend to increase. And genetics. Genes partly determine how much cholesterol the body makes. High cholesterol tends to run in family. So what is the profile of your client who has a high risk of cardiovascular disease? Who will present to you? What will they look like? Think about those factors that we just discussed. Our clients with elevated blood lipids will likely be 65 years and older. The National Heart Foundation in Australia reports that about 30% of Australians will die from cardiovascular disease, and most of these will be 65 years old. Also, those of Aboriginal and Torres Strait Islander origin are at greater risk. If your client smokes, has high blood pressure, type 2 diabetes, and is overweight or obese, they are at a greater risk. Also, as we've discussed, age, gender, and family history increases the risk too. In general, the higher the low-density lipoprotein cholesterol levels and the more risk factors that your client has, the greater their chances of developing cardiovascular disease. So how do we manage this? Elevated blood lipid levels can be managed by both pharmacological and non-pharmacological interventions. Clients with high blood cholesterol levels will often be given medication to lower blood cholesterol levels, and statins are most commonly recommended. Statins work in the liver to prevent the formation of cholesterol and therefore lower the amount of cholesterol circulating in the blood. Statins are most effective at lowering low-density lipoprotein cholesterol, or the bad cholesterol, but also have modest effects on lowering triglycerides and also raising the high-density lipoprotein cholesterol. There are also selective cholesterol absorption inhibitors, which are a relatively new class of cholesterol-lowering medication. These work by preventing the absorption of cholesterol from the intestine. Selective cholesterol absorption inhibitors are most effective at lowering LDL cholesterol, but like statins, they also have modest effects on lowering triglycerides and on raising HDL cholesterol. Also, resins. Resins work in the intestines by promoting increased disposal of cholesterol. Since the body uses cholesterol to make bile, resins work by binding to the bile so it can't be used during digestion. The liver then responds by making more bile. The more bile the liver makes, the more cholesterol it uses, leaving less available cholesterol to circulate through the bloodstream. And finally, lipid-lowering therapies. So there are a number of different lipid-lowering therapies that are administered. Most of these have side effects and are not as effective as statins in lowering LDL cholesterol, although they are important to be aware of as they are alternative therapies, especially for clients that have adverse reactions to the main medication. The Royal Australasian College of General Practitioners recommends that treatment should commence with a statin. If LDL cholesterol levels are not sufficiently reduced on a maximally tolerated dose of a statin, look to other therapies like the resin or nicotinic acid. So these agents may be used as a single therapy if statins cannot be tolerated at all. If triglyceride levels remain elevated, consider using one of the lipid-lowering therapies like nicotinic acid or fish oil. The good news is that there are a number of ways elevated blood lipid levels can be managed through behavioural modifications. And through these lifestyle changes, clients can subsequently reduce their risk of cardiovascular disease. How? Encourage your client to get support through their general practitioner or through other treating health professionals to change their diet. Reduce the amount of saturated fat and cholesterol in the diet, which helps to lower their blood cholesterol levels. To lose weight. Losing weight can help lower low-density lipoprotein cholesterol and total cholesterol levels, as well as raise the high-density lipoprotein cholesterol and lower the triglyceride levels. To quit smoking and to engage in regular physical activity. Exercise plays an important role in lowering the low-density lipoprotein cholesterol and raising high-density lipoprotein cholesterol levels. As I just mentioned, regular exercise and even a single exercise session has been shown to positively alter cholesterol metabolism. Exercise increases the production and action of several enzymes that function to improve high-density lipoprotein cholesterol levels, thereby affecting change in the reverse cholesterol transport system, that is, the system taking cholesterol back to the liver away from the arteries. Indeed, levels of high-density lipoprotein cholesterol have been shown to increase after aerobic exercise training. Studies have found that favourable changes in high-density lipoprotein cholesterol appears to occur incrementally and reaches statistical significance at approximately 1,200 to 1,600 calories of work per week. Exercise-induced changes in high-density lipoprotein cholesterol also appear to be gender-dependent, in that the volume of exercise required to increase HDL levels appears to be substantially more for women than for men. This may be due to the higher HDL levels in women at baseline compared with men, which we discussed earlier in relation to the pre- and post-menopausal women and their changing cholesterol levels. Moderate to low intensity exercise should be preferred because such exercise carries a lower risk for cardiac complications and has better long-term adherence than a higher intensity exercise program. Of course, the response of HDL levels will differ for every individual depending on the intensity, the duration, the frequency of the exercise, their initial levels, their gender, and the length of the training period. Regular monitoring of serum blood lipid levels should be done with your client. Of course, the aerobic exercise prescription should be individualised based on the health and the fitness level of your client. The exercise prescription should be progressively introduced to individuals that are relatively sedentary and or overweight. Encourage the use of moderate intensity exercise, ones that work large muscle groups equivalent to around about 1,200 to 1,600 calories per week. The optimal training frequency appears to be 3 to 5 times per week. However, I encourage you to work with your client to build up to the Australian recommended physical activity guidelines of at least 30 minutes per day on most, if not all, days of the week. Note, elevated blood lipids are not an adults-only presentation, and research has shown that measurements of serum lipid levels, blood pressure, and body mass index in childhood correlate strongly with values in middle age. Intervention at the early stages of life can have lasting effects. Lifestyle-based intervention studies started in infancy have been found to be effective and safe. For those on cholesterol medications like statins, we know that a healthy diet and regular exercise helps to support the pharmacological. So the main things I want you to take home from today. Blood lipids comprise mainly of triglycerides and cholesterol and are important for cell membrane integrity and function. As with most things though, too much of it is not a good thing. That is, very high levels of blood lipid levels in the blood are not good, and those with elevated blood lipids have an increased risk of cardiovascular disease. Medications and other pharmacological interventions are effective, but we should encourage our clients to make positive changes to their lifestyle and behaviours to reduce their cholesterol levels and to reduce their risk of cardiovascular disease, as it is often a combination of these lifestyle factors that puts them most at risk. It is important that we, as accredited exercise physiologists, can recognise our high-risk clients, and we encourage them to work up to the recommended 30 minutes per day of moderate intensity exercise. These are some great resources that you can go to for further information for you or for your clients, which I'm sure you're already aware of. Also, please feel free to contact me with any questions. Thanks very much.